Okay, right? Your sternum, your breastbone. Yes, it's actually three bones right here. The manubrium, right? Clavicle's attached there. Then the sternum in the middle, and then on the bottom, you have the xiphoid process, and the xiphoid process has two, and it's very common. They're not the same size, right? It's very common. I've seen that so many times on people. It's right down here. Yes. Okay, tell me you know who Bruce Lee is, right? Yes, Bruce Lee, yeah? Supposedly you could do the knife hand, right? And you're supposed to be able to break this off and shove it up into their heart and kill them because they're going to bleed out because you went, right? Yes? They didn't teach me that when I got my black belt, but anyway, that's the true stories. That's why, because they're pointy. I used to treat this one older truck driver guy right here, and his one side was really pokey and pointy. What is that? I'm like, no, don't worry, that's normal. So,
wait,
okay?
do you really have a black belt?
Yes. Yes. I really do. It's hanging in my office. You can see it. A real one. Yes. Took me like 4 years. Yes. Because I'm the kind of person that I don't commit to a lot of things lightly, but if I commit to it, I'm doing it to the max, right? I was about 40 when I got my black belt, and then after that, Bruce Lee had the best of any athlete. He had the best foot movement, right? The fencers. So that's when I went to AC and took up fencing to learn their footwork, right? Because the fencer, he does this, right? Almost never crossing his legs, almost never, right? So you can do this, right? And the most stability. But anyway, fencers had the best footwork. So I took that up to learn the footwork, and I loved it so much. I did that 14 years, yes. Mm-hmm. So, but anyway, fencers do cross the legs occasionally, and sometimes you do the desperation move, and you shove the sword arm out, and it's called a flesh. On an arrow, the little feathers, that's the flesh, right? And the flesh is, and you go running at them as fast as you can. That's a flesh, right? That's where it comes from, yes? So, anyway, yeah, you try to sneak up on the guy. You have to be very tricky to be a fencer. It's not enough to be athletic. You have to be very, very smart to be a high-level fencer. Because you have to outsmart the other guy. But anyway. Okay, ribs. Okay, a manubrium, sternum, xiphoid, right? Let's talk about the ribs, okay? Right? You got a dozen pair of ribs, and 7 of them are sternal, right? They attach to the sternum. 5 of them are what are called floating ribs, and they attach, 3 more are called, 7 of them are sternal, 5 of them are false ribs, okay? They don't attach to the sternum. 3 of them come down here and attach to each other, right? And then the 2 in the back, right? The 2 in the back, this one and this one are right here and here, and those are your floating ribs. They float, and they're not attached to the sternum. What is the purpose of the floating ribs back here? And what else is under there? Yes, yes, yes.
Your kidneys?
Kidneys, right? People don't realize. People go, oh man, I think I'm having a kidney infection. No, kidneys are way up here underneath those floating ribs, those kidneys, right? And the purpose of those 2 floating ribs is to wrap around and to protect those kidneys there, right? Okay. Now, can your back hurt way down here when you have a kidney infection? Yes. But most of the time, you know by then you got a kidney infection before it gets that bad. Trust me, you're going to the doctor, okay? But anyway, that's the purpose of the floating ribs, yes? And if you've ever fallen and hit, right? The ribs are for protection. They protect the heart, the lungs, but especially back here, the kidneys, right? Okay? And again, 7 sternal, and then 5 of them that don't attach to the sternum. 3 of them attach to each other and come up, and the last 2 are the floating on both sides. Okay? Okay, real quickly. Right? We talked about this is the spine of the scapula, and this is the acromion, this bone right here. The acromion articulates with the clavicle. This is the head of the humerus, okay? Now, the reason I mention that is because this joint right here, is the acromioclavicular joint. And again, most of the time we don't say that. Most of the time we say AC joint. It's a lot easier, right? Have you ever heard somebody, oh, he separated his AC joint, right? Or they will say, oh, he had a partial separation of his shoulder, right? That's the AC joint. Yes? Let me explain. It's tied together with ligaments. And because of that, it's tied together with ligaments. You can do this. You can do this. You can do this. You can do this. You can go, hey, come on. Right? Yes. Okay. You can move your shoulder that way. Thanks for being a good sport. You can move that shoulder that way. Now, if you lift something heavy, or you're on the line in football and you slam into the other guy and the shoulder gets pulled back, or you fall down, boom. Right? You can do it that way. I had a girl come in my office lifting a couch. She's a big, stout girl, and man, it must have been a heavy couch. But anyway, she separated that. Okay? What is the treatment for that? Painkillers, anti-inflammatories, and they will a lot of times put you in a brace to hold it back, right? Do they usually do surgery on that? Okay? If you play in the NBA, yeah, you're probably going to have surgery, right? But if you're not playing in the NBA or a pro athlete, they're probably not going to do surgery on you because can they put a screw in there? No. If you put a screw in there, you can't do this, right? Yes? The shoulder is the most amazing joint. It has the most range of motion of any joint in the body, but the problem is, because it's so free and it can move so far, it has the least stability, right? The stability, because it can move so much, see, is not good. So it's common to injure that shoulder. That AC joint is very common injury in football, very common. And what will happen is they show up and they go, oh, my shoulder. And you look at it, and the end of this clavicle will go, it'll be stuck up about 1/4 of an inch. So this one over here will be way taller than this one over here, right? It's very common. They go, is that ever going to go down? I say, maybe when you get to heaven, get that brand new body, but not till then. No, sorry. Not happening. Yes. Okay? It's very common, especially the big muscular guys that are on the line, the linemen that go and they hit each other and they wear shoulder pads, but still, it's very common to separate your shoulder. Okay? I had an eye doctor here years ago, my friend Dr. Dow, and he went up in basketball. He was a big, tall dude, about twice as big as me, just as tall. And he went up like that, and a big guy came down on top of him, wham, right on that shoulder and separated that shoulder. So, yep. Now, anyway, AC joint. I want to show you one thing in here. Okay. The end of this scapula here, this joint right here where the humerus attaches to it. If you notice, it's just shaped like that. It's very flat. And the humerus does this. So we can literally knock our shoulder out of socket, right? When I was a kid with the boys group, went, and one of the leaders, he jumped off the 20-foot diving board platform, right? And his arm came out like this, and yes, pulled his shoulder out of socket, right? Yes. and such. Swam over to the side. Hey, lifeguard, 17 feet deep the pool because the platform. I can't get out of the pool. You know, you gotta. Right next door was a hospital. But anyway, yeah, they knocked him out and laid him down and yes, put it back in shape. But anyway, yeah, major deal, major deal. But that socket is very shallow. The reason I mention that too is because that's called, let me draw the picture here. Okay, that socket is very shallow, right? And it's called the glenoid, Glenoid fossa, right? The glenoid fossa. But the thing about the glenoid fossa is you have a ring of cartilage right here, right? That the head of the humerus fits in. Yes? And that is called the glenoid labrum. Right? Yes? Years ago, we had a young lady from Dalhart that was an awesome volleyball player, right? Man, she could serve that ball. Yes? Her dad was my patient. And it's a very common injury. She tore that glenoid labrum, right? And they had to go in there arthroscopically and trim that labrum up and clean it up, right? She was so good, she went to the University of Colorado on a full ride scholarship, just playing sports for them, right? Girls volleyball, yes. And her dad told me the doctor did the surgery, and she said, "Well, I'm going to have trouble with this later." He said, "Yeah, sorry." Right? But anyway, got her free ride through college, University of Colorado. Pretty impressive, right? So, but anyway, yeah, amazing athlete from right here in Dalhart, Texas. Then after she went off to her college, her dad got a new job in Dallas. But anyway, backed me off. He's a nice guy. I really like that guy. Anyway, glenoid labrum. It's very common. I have another friend. Her son, like my son, was in the Marine Corps. And all the push-ups and all the lifting and all that, he tore his glenoid labrum here too, also. Okay? Because that socket is shaped like that, and that glenoid labrum is round and it's scooped like that, same thing, shaped like that. Okay? Okay. Okay. We already talked about the wrist or the carpal bones. There's 8 of them. And if you look at them, they're shaped like this. Right? It's an arch. Right? This is the, right, in the anatomical position, this is right here. And the arch is here over the back. But it's shaped like that. And that, again, median nerve, tendons, ligaments go through there. Right? And such. And again, when that nerve through here gets pinched, that's when you got the carpal tunnel. We have a lot more carpal tunnel than we used to. Don't know why, but we do have a lot more carpal tunnel than we used to. Some people think it's computers, right? And such, all the typing, but I don't know. Okay. Carpals, metacarpals, right? Tarsals, metatarsals, yes. Now, okay, let's talk about the knuckles, the fingers, right? The fingers and the knuckles, okay? The digits, yes? Okay? The fingers and the toes, they're called digits, but the bones are called phalanges. Phalanges, phalanges, right? Okay, the MP, the metacarpophalangeal joint. right? That's your knuckle. K-N-U-C-K-L-E, right? Right? Yes? Here, see the big knuckles? That's the metacarpophalangeal joint, right? Yes? Now, why do I mention that? What's the big deal about that? The big deal about that is this. Okay? Rheumatoid arthritis is a very common disease. By the way, who has more rheumatoid, men or women?
Women.
Women, yes. Okay? And it affects these metacarpophalangeal joints. And it destroys the joint in time. Some people have a very severe, but some people not so severe. Okay? Now, the joints here in the fingers, the phalanges, are called the pip and dip, right? Proximal interphalangeal joints, and the distal interphalangeal joints. Well, what do I mention that? Okay, the joints here, right? These across here, these are the pips, the proximal interphalangeal joints. The ones here are the dips, the distal interphalangeal joints, right? Distal, right? Further away from the midline, right? Why do I mention that? Because people say, I have arthritis in my hands, and let me look at that. And so I look at their hands always, and I will say, can you make a fist for me? Let me see your knuckles, right? And I look at these knuckles, right? And if the pain is in these knuckles, and it's a lady from 30 to 50 years old, right? And I ask her, does rheumatoid run in your family? Anybody in your family got rheumatoid? Right? She'll say, no. Okay, great. Then I look down here. I look at the pips, right? Does she have arthritis in them? Right? I got some crooked fingers from, right? Pips and dips. If the arthritis in her hand is in the pips or the dips, then it's probably osteoarthritis or degenerative joint disease, right? But if it's these knuckles, I'm like, okay, you need to go to your medical doctor and have them test you for rheumatoid, okay? I'm not saying you got it, but you need to go have it tested, right? Yes? Depending on whether it's the pips, the dips, or the metacarpophalangeal joint, right? The MP joint, right? People with rheumatoid, if they have it very severely, they get the hand like this. I don't know if you've ever seen that. There used to be a lady in town like that, and such. And that's called claw hand, because she could not move her hand like that anymore. They were so deformed, yes. But anyway, right? We'll talk more about that in a future chapter. But anyway, you will find that I will talk about something, and then a couple chapters later, I'll talk about it again, because if you get it more than once, you're more likely to remember it, right? So that's why I do that. Okay? Okay. Let's talk about the pelvis right quick, and then we will go over these. Yes? Did everybody get one of these? Yes? Okay, great, great. Okay, the pelvis, right? Okay, here we go. Okay, the pelvis is really made of three bones, right? The ilium, the ischium, and the pubic bone, right? Three bones grow together on each side, and that makes up the pelvis, okay? Yes? Now, the bottom of the pelvis here, right here and here, is the ischium. These are called the ischial tuberosity. My patients say, oh, it's my sit bone, right? Yes? The ischial tuberosity. Why is that a big deal? That's a big deal because you have a bursa, a fluid-filled bag down here, right? And sometimes that bursa gets irritated, right? When I grew up, there weren't no padding on the pews in church. It was hardwood, right? And if that got irritated, it was very uncomfortable. and it'll make pain go down your leg, and it'll make you have pain, it's a pain in the, anyway, yes, right? And so, ischial tuberosity bursitis, it's very common. It's very common, right? We talked about over here, greater trochanteric bursitis. You can get it over here. There's a bursa over here too, and that'll hurt around here and hurt down your leg. That's very common. Yes? Did I not tell you my story about that one? This lady comes in and she had, I checked her and I said, I think you got greater trochanteric bursitis, this and that. And she said, oh, I had that years ago. I said, well, usually you go to the doctor and they give you a cortisone shot and it really helps. And she said, when I had it years ago, I went to my medical doctor, the GP here, and she said he gave me a cortisone shot and it didn't help a lick. I said, really? What'd you do? She said, I went to the bone and joint clinic in Oklahoma City. And she said, I went to the doctor there and he said, oh, you have a greater trochanteric bursitis. And she said, I know, that's what my GP said. He said, I'm going to give you a cortisone shot in that. And the lady said, well, that's what my GP did. It didn't help a lick. And the doctor said, yeah, but I'm going to hit the right spot. He gave her the cortisone shot right into it, and it cured it for many years. But anyway, it was real funny. She said that doctor said, yeah, but I'm going to hit the spot. See, he's an orthopedic surgeon. He had done it thousands of times. The GP had done it once or twice a year, but that guy done it thousands of times, right? So anyway, okay, about the pelvis. Okay, here we go. Ischial tuberosity, right? This right here is a sciatic notch, one on each side. The sciatic nerve we'll learn about. 5 nerves come out of the spine, join together, make a big old fat nerve, the biggest nerve in your body, about as big around as your thumb, and it goes through here and here. You ever heard the old guy, oh, got sciatica? Sciatica means pain down the leg. It's not a specific diagnosis, but it's very common among older people. I've treated it for decades, right? But anyway, sciatic notch right here. As that nerve comes out and goes right down here. Oh, by the way, when I worked at the hospital in the early 80s, yes, a nurse, she gave someone an injection. She hit the sciatic nerve, injected that medicine right into the sciatic nerve, paralyzed the guy down. Major lawsuit, but anyway, right? It's very serious being a nurse. It's very serious. They're professionals. They're very highly trained professionals now. I got a lot of admiration for the nurses. But anyway, right? Okay. Now let's talk about. I don't know if you figured this out. Okay, pubic symphysis and the disc, right? What kind of cartilage? No. Hyaline is the most common cartilage of the body, but places like our spine or here where there could be some friction and pressure, sorry, don't mean to be graphic, but, right, you need the tough stuff there, right? Yes, so that's fibrocartilage, right? In the spine, and there's fibrocartilage, yes? The toughest, strongest type of cartilage, yes? Okay? Besides, it's got to be tough when the skateboard guys try to do the rail, right? And then they fall off and they cross the, yeah. That's why it's got to be there. Okay? The toughest cartilage, yes? Okay, now, okay, this is the head of the femur, and right up in here, this is the acetabulum. acetabulum, acetabulum, okay? That's the notch, yes? You have a very powerful ligament, right? You have a very powerful ligament, right? I'll think of the name of it in just a moment, that attaches right there. Oh, by the way, you also have an acetabular labrum. We heard that in the shoulder, right? But anyway, you have a powerful ligament in here that holds that in socket. Do people get their hip out of socket?
Yes.
Does that hip come out of socket? Okay? It's very rare. And if it did, you were in a plane crash or you were in a tremendous motorcycle accident, probably going over 100 miles an hour, okay? That is a very powerful ligament there that holds that in socket. People always come in and say, oh, my hip's out of socket, this or that, right? No, their pelvis is torqued and twisted, but I don't say anything, but technically, no. This is not out of socket, because if it was a terrible trauma. In fact, years ago, there was a little lady chiropractor about the size of Miss McKenzie, isn't that right? Yes? She was about your size, and this patient tried to sue her and say that, you know, he pulled my hip out of socket, you know? Trouble is, they had an anatomy professor testify and say, that little gal, there's no way she's strong enough or big enough. If she used all of her force, she could not pull that guy's, it was a big dude, hip out of socket. Sorry, that's not happening. She ain't powerful. Now, if you're in a plane crash or maybe a terrible motorcycle accident, possibly, right? So, but anyway, pretty funny, yeah. So, okay, right? Okay, now we got to talk about these right here. How many of you know men and women are different? Men and women are different, right? We are. We think different and we're shaped different, and our pelvis is different, right? Any good pathologist can look at a pelvis and see if it's a boy or girl very quickly, okay? Very quickly. Let's talk about that. Okay? Number one, why in the world do the pelvises need to be different in men and women?
Because women have babies.
Because women have babies, right? Yes, they do. Yeah. By the way, don't believe these people that say men can have babies. Sorry, not buying it. That's the most ridiculous piece of baloney I've ever heard, and they say it with a straight face. Did you see that woman testifying? The Supreme Court Justice Ketanji Brown. They said, could you define a woman? And she couldn't define a woman. She said, I'm not a biologist. Right? I was shocked. I'm not a biologist. But anyway, whoa, what is this world come to? But anyway, here we go, right? This is the pelvis, right? Okay? And let's talk about okay, the pelvic inlet. The baby sits here, but the baby has to go down through here to come out, right? Right? Vagina is down here, so the baby has to go down through the pelvis, right? Oh, by the way, the placenta, yes, we'll talk about that later. Placenta secretes a hormone called relaxin, and relaxin relaxes ligaments. What are you held together with down here? Ligaments, okay? So those are relaxed so the baby can come out, okay? If you look at this pelvic inlet, okay? If you look, right? A woman's pelvic inlet is much more round and a men's is much more heart-shaped because we love women, right? Yes, right? I do, yes. All my life, starting with my mom and then my wife, 35 years. Women been good to me all my life. I'm a big fan of women, right? Yes. But anyway, okay. Big and round, more oval, that's a woman. More heart-shaped, that's a man, okay? That's a difference, okay? More oval-shaped and rounder, that's for the baby's head to come out. The biggest part of the baby is his head, usually, right? Okay? And again, the man's narrower and more heart-shaped, okay? Now, the pubic arch, all right? The pubic arch. Sorry. Joseph, could you come up here and help me, please? Just so this guy don't fall off. Hang on to the stand or something for me. Right? This is the pubic arch right here, right? Can you see how narrow that is? Guess what? On ladies, it's wider for the baby's head to come through there, right? Right? Does that make sense? Is this a man or a woman, by the way? It's a man. It's pretty narrow there, and it's more heart-shaped up here. It's a man, okay? right? Yes? Okay, so the pubic arch is narrower on the man and wider on the woman. Okay? Yes? Okay. Okay, thank you, Joseph. I think that's it. Okay? The acetabulate, right? Right? Remember, that's the socket right here, the hip socket, the real true hip socket, right? Yes? Okay. Okay, the acetabulae are like this, and in ladies, they're wider apart, and in men, they're closer together, right? Yes, again, to make the pelvis bigger so the baby can come down through the pelvis, right? So these two sockets, if they're closer together, it's a man, and if they're wider apart, it's a woman. By having them wider apart, there's more room for the baby's head to come down through, right? Yes, it's really not complicated if you think about it, right? Okay. Ischial tuberosities, right? Okay. The set bones, the ischial tuberosities right here and here, right? Pardon me. Beef jerky. Okay. Those sit bones, right? On a man, the ischial tuberosities are more inverted, right? And in a lady, they're more everted, right? This is inversion, eversion. Okay? So in a lady, they're more everted. In a man, they're more inverted. They're closer together, right? And again, by being everted, that means there's more room for that baby's head to come through. If those were close together, the baby might bump his head, right? So that's what that's about, okay? And the coccyx, yes? Okay. You have 4 or 5 little segments here, the coccyx, and they're usually fused together. Not always, but they usually are. In men's coccyx, it's curved usually further up under. In ladies, it's usually further back. And again, it's just so the baby can come through in its head, right? So if that coccyx is sticking up to the front, forward, curved up under there, it's probably a man. And if it's more back, right? Ladies, have you ever fallen down right on your fanny? And, right? Yes. Now, I've done that many times, but I've never hurt my coccyx. But I've had a lot of ladies come in and say, oh, what happened to you? Oh, man, right? Because it's sticking out further to the back, and when they hit, they're more likely to injure it. Yes? Okay? Okay? Now, real quickly, one more time. The pelvic inlet, right? A lady's is oval, a man is heart-shaped, right? Okay? The pubic angle at the front here. Men is more narrow, ladies are more wider, right? Okay? Now, the acetabulate. Ladies are further apart. How many of you know men don't look good in ladies' jeans, right? They don't fit, do they? No, they don't. Okay? Men's acetabulate are closer together, and women's are, they're like this, okay? Men are closer together, see, and women's are further apart. By being further apart, there's more room for the baby to come down through the canal, okay? Right? Ischial tuberosities, right? Or sit bones here. Men, they're curved in, inverted. Ladies are curved more out, yes? Ladies have a wider pelvis, right? Am I telling you something you didn't know before? I don't think so. Okay? And again, the coccyx. Men's curved up under, and that wouldn't be good for the baby to come through and bang his head on the coccyx. So, in ladies, it's further back, usually. Okay? Yes? And again, ladies, it's more flexible, our book says, and men, it's more stiff, right? Yes? Okay? Now, newsflash. Not on the quiz, but on the midterm lab test. This is going to be down there, and you're going to put an M for man and a male and an F for female. Okay, I'm just telling you. It's very simple. If you think about it, it's really simple. Okay, what makes sense? All right. So You're going to have to know this, know this, know this. Okay? Great. Okay. Right. Real quickly, the femur, right? Your thigh bone. Your femur is the largest, strongest bone in the body. It can take 2 tons per square inch, right? When you jump, you can put up to about 280 kilograms of pressure per square centimeter. Okay? Now, real quick now, we're going to talk again about the difference between men and women. Who has more torn ACLs, men or women? How many say men have more torn ACLs? Okay. How many say women? Okay, I didn't count, but it's pretty close. Yes. Women have more torn ACLs, right? It is associated to tearing your ACL with your time of the month, ladies, okay? But let me tell you why, or one of the reasons. Okay? We just went through the pelvis and we said a man's pelvis, right? These acetabulae are closer together, right? Yes. And in a lady's pelvis, right? These are wider apart, yes? Because these are wider apart, ladies, okay? Let me explain. They measure the angle here. It's called the Q angle, yes? And what happens is, if you look at me, my shoulders, my hips, and my knees are pretty much in a line, okay? However, ladies with a wider pelvis, right? The wider pelvis, it's the same. Shoulders, hips, and knees pretty much in a line. However, this angle is much sharper, the Q angle. I believe that's the way they measure it, okay? What I'm saying is this. Sorry. What I'm saying is this. If you look here, it's almost straight down to the knees. And the ladies, because the acetabulate are wider apart, it's much more of an angle this way, much more of an angle that way, right? And so the knee is like this, right? Which athlete has more knee trouble, men or women, probably? Women. Why? Oh, by the way, who has more knee replacements, men or women?
Women.
Women, right? Part of the reason for that is this angle. Because the pelvis is wider, the angle is sharper, and it's not. In a man, it's much straighter down to the knees. In a woman, because it's more narrow and then down, like that. And so because of that, there's a different physiologic stress on the knees. So women tear their ACL more. Now, part of the reason for that is, they claim, is that when a man goes up for a rebound, he jumps and he comes down with the knees bent, right? And they claim that for some reason women, when they go for the rebound, they come much more stiff-kneed, right? Much more stiff-kneed, okay? And so there actually are camps where they make, like, high school girls go through and they make them do jumping exercises and jump over stuff and things. And they teach them that, so it becomes a reflex to bend their knees. I don't want to take too much. I got to do jump rope when I get home, so I don't want to jump too much. That's yeah. I got to do jump rope tonight. So what I'm saying is, because the angle anatomically, women are different. Their knees wear out more. Now the other thing is, and I have to be careful. I don't want to hurt anybody's feelings, but facts are facts. if we carry more weight, we put more weight on the knees, and we wear the knees out faster. My father, at 75, still had his own hips and knees, right? Yes? I have a patient, bless her heart, she's like 93 years old now. I don't usually see her anymore, but I did for many years. And in her 40s, she had a knee replacement. In her middle 60s, she had a knee replacement. And 75, she had her third set put in. And she said, I need another set, but I don't want to do it a fourth time. Right? She was very heavy lady, okay? But anyway, so it comes from the different Q angle, the different angle of the pelvis, right? Women are wider here, and they're more angled out to the knees, right? Yes, don't ever let anybody tell you men and women are different. So, okay, biology is biology. Sorry, XX, XY, right? Yes. Here we go. Here we go. Okay. Right, the kneecap is called the patella, which means pan, and it's shaped just like this. This is the posterior, and this is the anterior, right? The front of it's nice and round, but it has two notches on the back. It has two notches on the back because of the condyles. Because of the condyles, well, I'll just draw it. The bottom of that femur looks like this and like this, and these are called the condyles, right? And so that patella rides right here, and it's got two notches in the back, here and here, to ride on those femoral condyles. And oh, by the way, one of the condyles is bigger than the other, so they're not exactly, the notches are a little off. No, they're not exactly symmetrical, the same size, I should say. Okay? Okay? Okay. Just a little bit more. Just a little bit more, right? Yes? Did we talk about sesamoid bones?
No, sir.
Okay. All right. I thought I forgot that. Okay? Okay. Sesamoid bones, really simple. Really simple. Okay? Now, especially you find these in the feet. That's what reminded me. We're going to talk about the feet for a minute. But it's very common. You see a metatarsal like this, and then you see the phalange here. That's the big toe, and then you see this one, and like that. It's very common at this joint here. There's another bone right here and another bone right here, right? Oh, by the way, in the sutures of the skull, it's common that you will have little bitty, right? Coronal suture, mid-sagittal suture, squamous suture, and lambdoid across the back. Anyway, it's very common you'll have a little bone in here, right? And those are sesamoid bones. And they're accessories, and everybody's different. Some people don't have them. And like in the big toe here, they help that big toe track properly. Okay, they're in the tendon, yes. And again, they're called sesamoid, S-E-S-A-M-O-I-D. And I never knew where that came from. And a year or two ago, I read, because I'm a geek, anyway. I read, yeah, you know what a sesame seed is, right? 2 all beef patty, special sauce, lettuce, cheese, pickles, onions on the sesame seed bun, right? Sesame seed, that's where they came up with that. Because they're little bitty round bones, and they thought it looked like a sesame seed, so they called it a sesamoid bone, right? Okay? So, sesamoid bones. Some people have them, some don't. They're very common, especially right there. I've seen that hundreds of times on a film of the foot, right? And again, you have some of them here in the seams and the sutures, which we'll talk about probably next time, right? But anyway, sesamoid. Yes? Now, right lower leg, tibia, fibula, okay? Tibial plateau down here, right? Patella, femur, and this bone on the outside is the fibula, F-I-B-U-L-A. This is the tibia, right? It's very common to fracture this tibia right here. You jump up and you come down and your foot lands like that, and you sprain your ankle real bad and it breaks the end of that off, right? This is a lateral malleolus. This is the end of the fibula, okay? A fracture down here across there, very common, is called a POTS, P-O-T-T-S, a POTS fracture, right? Okay? Can you walk if you have a POTS fracture?
Yes.
Yes, it's very painful, but you walk like this, but yes, you can walk, right? Most of the weight is borne in the big bone, the tibia, right? Okay? But you can walk. It's very common, unless it's displaced or something. Now, my next door neighbor in a softball game sliding into base fractured the end of that, and the doctor went in there, took him like 10 minutes, and he put a screw in it because he messed up bad, real bad. But anyway, most people, it's a little crack across there. It's very painful, hurts like heck. You limp, and they'll put you in a boot. Don't even do surgery on most people. It's a POTS fracture. It's very common. The fibula. This helps for muscle attachment and for balance a lot, okay? Now, on the front right here, your patellar tendon comes down and attaches right here, up here, right? And where that attaches right there, especially more commonly in little boys, right? They're 7, 8, 10 years old, 12 years old, and that tibial tubercle, the front there has not all solidified. It's not hard bone yet, right? And if you tear that jumping off of stuff, and I was a very active child, if you haven't figured out, right? Jumping and running and riding my bike and doing all kinds of stuff. What's very common, that gets irritated and it can get pulled away, and that is called Osgood Schlatters disease. And the main treatment is they'll put you in a little brace and they'll tell mom, dad, no sports for a year, right? And because you're not pulling, and tractioning on this all the time, not playing sports, not running around, then it'll heal up. It's very common. Osgood Schlatters disease. Very common. Okay? Okay. Real quickly, let's talk about the foot. The foot is amazing what it does. It carries our weight around. It's flexible. We can feel the ground. Okay? Now, okay? The foot, right? The foot has 3 arches. Okay? The transverse, right? Medial and lateral longitudinal. I want to make sure I'm right. Yeah, exactly. Medial and lateral longitudinal. Medial, longitudinal arch, and the lateral longitudinal arch, right? The transverse arch is across the ball of the foot. People don't realize that. It's a triangle across there, yes? You have an arch here, an arch here, and an arch here, yes? Commonly, as we get older, we gain weight, we get heavier, and we put stress on this medial arch, especially for an overpronator, right? Our feet that turn this way, I'm a real bad overpronator. or my foot turns out, right? Some people are the opposite. About 20%, their foot becomes inverted, right? It's very stiff. That's a supinator. About 20%. Most people are overpronators, and their ankle is very loose and it turns too far. Okay? When our foot hits, it should hit here, come down, and then roll flat. That's a normal step. But if it rolls too far, then we are overpronators, right? You buy motion control shoes. But because of that overpronation, it stretches this arch. And people have a lot of problems, right? And they have to wear arch supports. Yes? Right? Most of the time I wear arch supports, especially if I'm doing sports, like I'm going to go home and do the jump rope, and I definitely wear the arch supports then, right? And when that stretches, we get the plantar fasciitis, and the bottom of our foot hurts, and it's miserable, right? Now, we'll talk about two foot conditions, right? Number one, if you look at this arch here across the ball of our foot, those metatarsals, there's your arch, right? Well, it's common, if this is the big toe and this is the little toe, it's common this one right here wants to do this, okay? And when that drops down, it's called a dropped metatarsal, right? The condition is called metatarsalgia. Algia means what? Pain. Metatarsalgia, okay? A dropped metatarsal, right? Because this arch has been stretched, and it's most commonly that fourth toe, it drops down, and you get pain right there up under the foot, right? Yes? What athlete, by the way, it's very common to have that problem. What athlete?
Basketball.
I'm sorry, say it again.
Basketball.
Good guess. No.
Football.
Good guess. No.
Runners.
No.
Tennis.
Huh?
Tennis.
Tennis? No.
Soccer.
Think outside the box, kids.
Weightlifters. Golf.
Weightlifters? Golf? No.
Water polo.
No.
Volleyball.
Gymnast.
I used to be one when I was much younger.
Bodybuilder.
No.
Baseball.
Thank you for that. Thank you. No. Right? No. Rock climbers. Rock climbers put their toes on tiny little bumps in the rock. That's not a sport. You say that again, I'm throwing you out of here, sir. You are getting an F in this class. That is tremendously athletic. What are you talking about? Yes. You put your toes in there, and you put tremendous pressure on this tiny little nubbin that you're standing on, and all your body weight goes there while your other foot moves up. And it puts tremendous stress, and it's very common. Rock climbers will get a drop metatarsal. That's very common too. Ladies wearing real super high stiletto heels, right, which are not really good for your feet. If they do that a bunch, right? Yes? So, when you were in the Miss Hawaii, did you wear stilettos, Miss Leilani? No? Oh, good. She was wise. She didn't do that. She was in the Miss Hawaii contest. Okay? Now, drop metatarsal. Very painful. Now, they'll put a pad up under there commonly. The podiatrist will put a pad up under there just behind the ball of the foot to support it and to push up on it, right? It's very common. Sometimes they'll give you a cortisone shot under there and this and that. But it's very common, metatarsalgia, drop metatarsal. Okay? Yes? Very common. And again, I think you can see that. Rock climbers, they put their toes on very, very thin stuff. Very thin stuff. And then they put all their body weight on there, right? Yes? Gotta have 3. 2 hands, 1 foot, 2 feet, 1 hand. You only move 1 limb at a time when you're rock climbing. That's the rule. It's a rule. You never violate the rule, right? And such. Yeah. It's funny. this last weekend, coming down the $1 Million Highway in Colorado, I had to go first. My friend doesn't like heights, and I'm an old rock climber, and so he's like, you got to go first. Oh, okay. Because you're driving down that highway, and there's a bunch of hairpins, and it's straight down several hundred feet on one side. If you go off, you're dead. You're just dead, you know. So, no, I'm serious. Yeah, and no guardrails. Yeah. And so, pretty amazing. So I went first, and I went really slow, and I didn't scare him because I'm a nice man. And but anyway, okay. Now, the one other condition I want to talk about is this. Okay. If we look at the top of our foot, here's the ankle mortise, and here's the metatarsals. Okay. Yes. Right. This is the big toe, and this is the little toe. It's very common in between those metatarsals. We'll have a nerve come down and a blood vessel come down in between. I should do a different color, right? Makes sense. We have a nerve come down in between these. Yes? Now, what can happen is, how many of you know when you're older, your feet get a little funky and twisted and they don't, your toes get weird? Yeah. Okay. What can happen is that nerve can literally get pinched right in here. And when you get irritation on a nerve in the foot like that for a very long time, it causes a little tumor, a benign tumor, but anyway. And it's called a Morton's, T-O-N''S, Morton's neuroma, N-E-U-R-O-M-A, neuroma, right? A Morton's neuroma. So what happens is, you get pain in the foot, and again, not always, but most of the time, the vast majority, they're going to be between number 4 and number 5 toe. Right in here, you get pain, you get discomfort, you get pain in the bottom of the foot, you get pain in the top of the foot. You may have numbness and tingling in the lateral toes, okay, from a Morton's neuroma. And what happens is that the podiatrist will first try to put a cortisone shot in there and get that to calm down. If not, he does a surgery and he makes more room by chipping out so that that nerve is not pinched, right? But it's very common. It's very common to have a Morton's neuroma, more common in ladies. Okay? Yes? The Morton's neuroma and metatarsalalgia. Yes? Podiatrists, that's how they make their living, treating those. Yes? Okay. What's going to happen on Monday? We're going to have a quiz first thing. Do not show up late for the quiz. Because if you miss it, you miss it. And I'm not going back. Okay? So, this is your chance to make 100. Right? What do you need to know? You need to know all the things we went over on that sheet, right? Abdominal, brachial, all of those, right? And you need to know the 6 membranes, but really there's 3. But there's visceral, parietal, are the 3, right? Pleura, pericardium, peritoneum, right? Visceral means organ. If the membrane touches the organ, it's visceral. For your answer, you must say visceral or parietal, and then tell me the name of the membrane, the serosa, okay? If you put peritoneum, that's wrong. You write either visceral or parietal peritoneum. Visceral or parietal pleura. Visceral or parietal pericardium, right? Okay? Right? You don't have to spell it exactly right, but if it does not have 2 words there, you're wrong, even if you get peritoneum right. If you don't tell me if it's visceral parietal, then sorry. Yes? I told you, listen to me. I told you what's going to be on that test. That sheet, all those terms, and the 6 membranes. Right? You know what's going to be on there. There's no excuse for not making a good grade. This is your chance to bump your grade up and pass this class by the stuff that's very easy. This is very easy, right? And if you make a bad grade, I'm not going to feel bad, and I'm not a bad teacher. This means you're a lazy student, all right? Okay? So, be here. Know your stuff and make a real good grade. A lot of people make 100 on this one, okay? It's going to be a short quiz. It's going to be about, I don't know, 10 or 12 questions maybe, okay? Right? Yes? So, do good. Do good. And again, I'm not going to feel bad if you don't do good. Sorry. Okay? All right. See y'all. Have a great weekend. Yes? Have a great weekend.
Don't forget your stuff.
Oh, thank you. Thank you. Thank you.